Good evening to all respected seniors and my dear colleagues. Today, we are going to start our clinical meeting on the topic all about the ectopic pregnancy, started with Ma Saraswati Vandana. Saraswati Mahabhage Vidde Kamalalochane Vidyarupe Vishalakshi Vidyam Dehi Namostute. हे महाभाग्यवती ज्ञान रूपा, कमल के समान विशाल नेत्र वाली ज्ञानदात्री सरस्वती, आप हमें विद्या दीजिए और हम सब आपको प्रणाम करते हैं. एंड थ्रू दिस क्लिनिकल मीटिंग वी ऑल रिक्वेस्ट टू आवर ऑल सीनियर्स टीचर्स गाइड टू गिव अस लॉट्स ऑफ knowledge, sagity, and in turn we all thankful to you and have our pranam. As we know, the ectopic pregnancy is an adventurous journey. I request all of you to become a part of this adventurous journey of ectopic pregnancy along with our 9 speakers. And at the end, we have a sweet dish. So let us begin our clinical meeting. I would like to request Dr. Arun Guge come on the dais to present first clinical case presentation on unruptured ectopic pregnancy gestation having dilemma. Dr. Arun Guge has done her DGO and now doing in-service MS, has working as a resident in Civil Hospital, Solapur. Dr. Arun Guge, please come on the stage. Over to you, doctor.
A very good evening to all, respected teachers, my colleagues and seniors. I am very thankful to the Solapur Obejaya Society to giving me an opportunity to share my experience to last case which we have doing in our institute, that is unruptured ectopic management dilemma. My patient was a 32 years, gravida 3, para 1, living on ectopic 1 with 2 months of amenorrhea. She came with USG report suggestive of 3.5 into 3.7 centimeter size, well-defined heterogeneously echogenic solid cystic lesion in left adnexa with peripheral vascularity showing, which suggestive of ectopic pregnancy likely left ovarian ectopic. Patient was asymptomatic on coming. Obstetric history was she was gravida 3, para 1, living 1, ectopic 1, married since 11 years. Her first pregnancy was para 1, live 1, full-term vaginal delivery, female child 10 years. The ectopic pregnancy was right-sided ruptured tubal ectopic pregnancy, 3 months with 3 months amenorrhea, which required exploration and right salpingectomy. Menstrual history was LMP 1 April 2024. Accordingly, EDD was 8 January 2025. Her past menstrual cycles were regular. Her past present family history was significant. She has a history of pulmonary COX 10 years back, for which she completed CAT1 anti-COX treatment. She had given history of exploration and right salpingectomy, with her discharge card showing severe hemorrhagic shock at that time, which required multiple transfusions and inotropic supports, and ICU admission for about 23 days for dilated cardiomyopathy 2 years back. On examination at present, she was average build, GC was fair, afebrile, pulse was 88 per minute, BP was 110 by 70 mmHg, no pallor and no icterus. Systemic examination was normal. Per abdomen was soft. History, evidence of previous laparotomy scar was present. There was mild lower abdominal tenderness was present. Per speculum examination was within normal limit, and there were no active PV bleeding. PV examination shows uterus with normal size, soft, anteverted, anteflex, with left fornix tenderness was present, and bogus solid cystic lesion of 3 into 4 centimeter size average felt in left fornix. Right fornix was free. Relevant investigations was done, which shows that UPT was positive, blood profile except beta ECG, thyroid profile and routine examination blood reports were normal. On day of OPD follow-up, her beta ECG was done, which shows that it is 1042 milli-international unit per ml. This was her TVS scan report showed solid cystic lesion in the left adnexa. ECG was done, which was normal. As she had given previous history of ectopic and prolonged morbidity with dilated cardiomyopathy, prolonged ICU admission, we had done 2D echo of that patient, which shows normal chamber dimension, good left ventricular cystical function, If ejection fraction was 60%, no mitral tricuspid or no PH was there. As patient was asymptomatic, vitally stable, and UAG suggestive of no hemoperitoneum, with all risks explained to the patient and relatives in written. Decision of expectant management taken with monitoring of vitals, TVS scan done on twice a weekly basis, serum beta ECG done, values are followed. On day 3, it was decreased from 1042 to 791 milli-international per ml, and on day 7, it again repeated, which was 284 milli-international per ml. On day 8, patient was stable and we are ready to follow up every week. So we have discharged her and follow up after 1 week. And after 1 week follow up, her beta ECG today was 112 milli-international per ml. TVS showing that there is a decrease in size of lesion with no evidence of any hemoperitoneum. Patient advised next follow up in next week. The criteria for the expectant management are according to RCVG, ACOG and NICE guidelines are beta ECG 1000 to 1500 milli-international per ml. According to Williams, it is 3000 milli-international per ml. Ectopic gestational sac size should be 3.5 to 4 centimeter or below that. There should be absent cardiac activity. Patient should be basically hemodynamically stable and asymptomatic or mildly symptomatic. Patient should be ready to timely follow up with all explained to the patient regarding the emergency surgical management may be required. Decrease in beta ECG values is more than 50% on day 2, day 4 and day 7, and follow up weekly till beta ECG goes below 20 milli-international per ml. Usually that takes 2 weeks, but rarely 3 months could be required for the follow-up required. The various studies show that 70% cases resolve with the expectant management. Next, normal pregnancy incidence is more with expectant management than medical management than surgical management. This is a cost-effective treatment and least invasive. These are the normal chart for management of ectopic gestation. Expectant management, which we have done. Medical management, which is UAG or laparoscopy. Local salpingocentesis. In the following drugs are used in that methotrexate, rarely potassium chloride for study purpose, prostaglandin, PGF2 alpha, hyperosmolar glucose, actinomycin D, and mifepristone. In medical management, systemic methotrexate is most commonly drug used. And as we all know, surgical management is radical salpingectomy or conservative surgeries are salpingostomy, salpingotomy, segmental resection, milking of femora or expression. Thank you all. Thank you very much.
Sir, when you saw in the UAG there is a mass, what are the DDs?
Yes.
What differential diagnosis are in the
differential
mind?
diagnosis could be that is tubo-ovarian mass. It could be tubo-ovarian mass. It could be chronic PID with endometrioma. But beta ECG levels were high, so that was BS thought it is
It is 1200.
Yes,
42.
1042.
42.
Yes, UPT was strongly positive with 2 months amenorrhea.
Why not? Is it a chemical abortion? Beta ECG written how many days within normal limit?
Usually it takes 2 weeks. Usually it returns to normal in 2 weeks. But sometimes it takes 3 months also.
For ectopic and for normal pregnancy abortion?
Normal pregnancy after 40 days it usually comes to normal in 40 days.
So why it is ectopic? I am asking that.
The mass is mass in left adenexa with history of previous tuberculosis with previous ectopic. It is more likely to be a ectopic. Previous history of tuberculosis that suggestive of some pathologies already existing in the adenexa.
Sir.
Could it be corpus luteum on that side with ectopic situated somewhere else, pregnancy of unknown location with corpus luteum? Because your findings told me that there was a cystic lesion in the left ovary with hypervascularity, right?
Yes, sir.
So, can it not be a corpus luteum? Was it thought of?
No, serum beta ECG level was significantly elevated.
Yeah, I mean, unless there is a corpus luteum, there will be no pregnancy. Point number 1. Okay, beta ECG will rise if there is pregnancy, and pregnancy could be an unknown location. why did you label that as an ovarian ectopic? That was my question on ultrasound.
That was the radiologist opinion. We also thought that it is. We
You also thought that it could be corpus luteum.
No. We also, as beta HCG was significantly elevated, and there USG pelvis and abdominal was also done. There was no other site showing pregnancy at other sites.
No, my another, sorry to discuss because Dr. Vijay Power is not here. But see, Vijay Power is here. So I want Vijay Power to be here. Yeah. No, my question is, this patient had a catastrophic evidence, incidence in the previous ectopic, right?
Yes, sir.
So then this time when you thought that it is ectopic, was it not something too much stretching to think about expectant management?
Sir, there are two differential, like you already said, corpus luteal hematoma or rupture of that is also one possibility. And second is like it may be a failing pregnancy.
That's
so
right.
Because and ectopic. So these are the three differentials.
It would be failing ectopic.
So failing pregnancy is again one of the difference. So that's why we were reluctant to give her methotrexate. So methotrexate we thought we should not give. We'll see how the beta HC is going, whether it is early pregnancy and whether it is growing. The radiology diagnosis was a ectopic pregnancy, but in the back of the mind all this possible. That's why we didn't go for a surgery and methotrexate. So
because patient was asymptomatic anyway.
Asymptomatic. So,
and you didn't want to miss the chance of her growing intrauterine pregnancy.
Yes.
You
So
thought
since her beta HCG was following, her tenderness, probe tenderness also started reducing. So we thought that better not to do anything for her. And because last time when she had ectopic, she was post-operatively lot of morbidity was there. She was in ICU for many days. So that was one aspect, and it should not happen that you give methotrexate, overdiagnose, and you kill a pregnancy which is growing intrauterine. So that was one possibility. That's why we thought just wait and watch. Because when the patient was informed to me, they said no, we'll start on sir methotrexate.
That was the dilemma in mind.
So I said just wait and watch, don't jump to conclusion.
To go for medical management.
Just see how things go. And over a period of time, the beta HC was falling, patient was asymptomatic. I said, let's wait and see. It may be a failing intrauterine pregnancy.
So how many years you took to know that when not to do is a wise thing?
It takes
That
a lot
was
of
really
time,
nice.
sir. It
Good.
takes 5-10 years.
What are the chances that this tube may remain patent?
Thank you, Dr. Arun Guge. Nice case presentation. Next, I would like to invite Dr. Sneha Devkar. She has completed her MBBS from Government Medical College, Latur, and MS OBGY from KNS Salve, Nagpur. Worked as a senior resident for 1 year at Symbiosis Medical College of Women. At present, she is a gynec consultant at Unique Hospital, Solapur. Over to you, doctor. She is presenting a case on uncommon corneal pregnancy.
Good evening everyone and all respected seniors. Here I am presenting case of uncommon corneal ectopic pregnancy under guidance of Dr. Ajit Gandhi sir. 32 years, gravida 4, para 2, live 1, D1, abortion 1, presented with complaint of amenorrhea of 2 months and with complaint of abdominal pain and complaint of generalized weakness. Her menstrual history was she had regular cycles of 25 to 28 days with average flow. Her obstetric history, first was male child which was died. It was preterm vaginal delivery and it was died after 8 days. Then the second was live issue. It is 7 years male preterm vaginal delivery, and third is abortion, which is 1.5 months spontaneous abortion. So on her examination she was stable. On per abdomen examination tenderness was present, and on per vaginal examination cervical motion tenderness was present and also left fornical tenderness also present. On her medical reports she was stable and with UPT positive. Her USG was done on transvaginal sonography. It was suggestive of isoechoic lesion measuring 36 into 33 mm noted in left adnexa with fetal pole seen within with CRL 15.88, that is 8 weeks. Cardiac activity was noted. So impression was these findings are suggestive of left cornoisthmic live unruptured ectopic pregnancy. So plan of emergency laparoscopic surgery as well as exploratory laparotomy was made. consent was taken, and under general anesthesia, procedure was started. Intraoperative findings were an enlarged protuberance is found lying outside the round ligament and coexistent with normal distal fallopian tube and ovary. Laparoscopic surgery with corneal resection and left salpingectomy done. And then tissue was sent for HPR. Post-operative care, she was shifted toward antibiotic coverage was started, and she was monitored routinely and discharged on post-op day 3. As patient was in reproductive age and willing for further conception, so fertility has been preserved. At present, patient has been conceived, and today her gestational age is 16 plus 3 weeks. Thank you. Okay, sir. At present, the corneal ectopic pregnancy is called an interstitial pregnancy. It is more correct word. It is one that implants within the proximal tubal segment that lies within the muscular uterine wall. It is a rare event constituting only 5% of all tubal ectopic pregnancies and is associated with a high rate of complications. Undiagnosed interstitial pregnancies usually rupture following 8 to 16 weeks of amenorrhea, which is later than for more distal pregnancies. This is due to greater distensibility of the myometrium covering the interstitial fallopian tube segment. Because of proximity of these pregnancies to the uterine and ovarian arteries, hemorrhage can be severe and associated with higher mortality rate of 2.5%. So, what are the differential diagnoses? The gynecological differentials are ruptured ectopic pregnancy, ruptured adnexal mass, ovarian torsion, ovarian cyst rupture, tubo-ovarian abscess, and salpingitis. The non-gynecological differentials are cystitis, gastroenteritis, renal stone, and appendicitis. Diagnosis, it is made on after clinical examination. It is basically depends on transvaginal sonography. Criteria for interstitial ectopic include an empty uterus, a gestational sac seen separate from the endometrium and more than 1 centimeter away from the most lateral edge of the uterine cavity. This is important. An echogenic line known as interstitial line sign extending from the gestational sac to the endometrial cavity most likely represents the interstitial portion of the fallopian tube. In unclear cases, MRI and diagnostic laparoscopy can be done. So here is the USG image where white arrow shows endometrial cavity and the black arrow shows gestational sac. There is the thin line which is connecting these two, which is called as interstitial line sign. Then medical management consists of methotrexate administration. Surgical management include mainly laparoscopic or even laparotomic, corneostomy or corneotomy. Then the third modality is local methotrexate injection. Treatment is performed with hysteroscopy under ultrasound guidance. Under local anesthesia, drug injection is made in the gestational sac and in the near myometrium. This procedure, when applicable, has showed very good outcomes. Then what is medical management? Ideal candidates to systemic methotrexate administration. Women that show no severe abdominal pain, she must be clinically stable. Ectopic pregnancy with diameter smaller than 35 millimeter with no detectable heartbeat. And serum beta HCG level should be less than 1500 international units per liter. The dose is 50 milligram per meter square. High probability of methotrexate treatment failure is found for patients with more than 9 weeks amenorrhea, beta HCG values more than 5000 international units per liter, crown rump length more than 10 mm, embryo with detectable cardiac activity. So, about surgical management, laparoscopy or exploratory laparotomy can be done. Corneal resection, that is corneotomy, it removes the gestational sac and surrounding corneal myometrium by means of a wedge resection. Then corneostomy, incision over the cornea is made and suction or instrument extraction of the pregnancy is done. After surgical management of interstitial ectopic pregnancy, if patient conceives, caesarean is preferred to deliver baby, but there is also evidence of normal vaginal deliveries. Yes. There is also video. Video play करें.
कुठला?
1 1 1 1. The surgery was done by Dr. Ajit Gandhi sir. So here it is ectopic pregnancy. It is interstitial. Actually, ma'am, coronal pregnancy, it is either angular pregnancy or interstitial pregnancy. If it is more toward yes, it is corneal ectopic pregnancy. It is either interstitial or angular. Angular, it is more towards the uterus, and when it is more towards consists of the fallopian tube, then it is interstitial pregnancy. दूसरा three. Yes. The corneal resection was done. Yes.
Case is present here? Okay. Okay. So this was a case of ovarian ectopic.
Corneal ectopic.
Corneal change. Okay. This is a case of corneal ectopic.
Actually, corneal ectopic, they say if it is in the accessory horn of the uterus, then it is corneal. This looks interstitial, she said, interstitial portion of the tube.
Interstitial
portion of the tube.
For resecting this, I use the insil energy. It's a controlled bipolar energy which senses the tissue impedance and then it stops the hay. Auto stop. Discharging the current. No, nothing. Just left it. Now this patient is now pregnant again. She is at
16 weeks.
16 weeks. Yes, she will. This time she will need elective. And, she has quite a tragic obstetric history. She has one child who has a developmental delay. And sorry. Yes, this time it will be elective seizure.
So the question remains that part of the myometrium is now weak.
Yes.
So could you put stitches there so as to prevent the rupture in the next pregnancy that takes place?
No, I haven't gone that deep. And there is one more thing which we had done is we had done a MRI before she planned next pregnancy. and we checked the corneal thickness on the MRI, and then since it was adequate, then we allowed her to go for next pregnancy. Sorry? Okay.
Thank you, sir.
Two things. One is we instilled the vasopressin before we started the surgery, and that has reduced the blood loss. Almost it was a bloodless surgery. And after finishing, you may find some small bleeders which you need to do a bipolar coagulation before you close the surgery.
Anybody want to any questions? While looking the video, can ask.
Remove the specimen. It's quite a tough specimen. There's a 10 mm trocar in the subpubic.
Thank you, sir.
सर ह्याच्यामध्ये मेथोट्रिक्सेट आपण ट्राय करू शकत नाही म्हणजे का
No, methotrexate is not indicated for such kind of pregnancies. When they rupture, it's a catastrophe.
म्हणजे अंडर ऑब्झर्वेशन ठेवून 1-2 दिवस
No. Her beta HCG was also pretty high.
Thank you, Dr. Sneha. I would like to invite Dr. Khate madam and Vijay Pawar sir to felicitate Dr. Arun Ghuge sir. Dr. Ajit Gandhi sir to felicitate Dr. Sneha Devkar. I would like to invite Dr. Samruddhi Gite. She is a junior resident at Ashwini Rural Medical College Hospital and Research Center, Kumbari. Has done her MBBS from Topiwala National Medical College and Nayar Hospital, Mumbai. Presented paper and poster in ART Summit conferences. Over to you, doctor. A case of rupture interstitial ectopic pregnancy.
Good evening everyone, good evening teachers, good evening my friends. I am presenting a case of ruptured interstitial ectopic pregnancy under the guidance of Dr. Vrunda Chaudhary madam, Professor and HOD, and Dr. Snehal Pawar Madam, Senior Resident at Department of OPGY, ARMCH, Kumari, Solapur. So, here I am presenting a case of patient 23-year-old, Gravida 2, Para 1, Living 1 with previous 1 FTCS presented in casualty at 10 p.m. with history of 2 months of amenorrhea, per vaginal spotting since 3 to 4 days, severe pain in abdomen, moreover hypogastric region since last 3 days but aggravated since last 3 to 4 hours. She had a complaint of vomiting 3 to 4 episodes since last 3 to 4 hours, weakness and giddiness. In history taking part, the most significant history about her, that was the menstrual history of irregular cycle since last 3 years, and she had menstrual of cycle of 1.5 to 2 months and for 3 to 4 days. On examination, patient was conscious, cooperative, but severe degree pallor was present. She was maintaining SpO2 on room air, and patient was tachycardic with pulse of 104 beats per minute with feeble pulse, and hypotension showing BP less than BP of 90 by 60 millimeter of Hg. On systemic examination, it was within normal limit. On per abdominal examination, guarding was present and there is raised local temperature over hypogastric region. On per speculum examination, cervix vagina was healthy, and on per vaginal examination, uterus anteverted which were of normal size, bilateral fornicial tenderness present, and cervical motion tenderness was also present. So, my provisional diagnosis on this was 23-year-old Gravida 2, Para 1, Living 1 with previous 1 FTCS with ectopic pregnancy. So, investigations I did, what UPT was positive with HB of 5.8 and WBC's platelet was within normal limit and blood group was O positive and sero status were negative. So, her USG sonography scan was done, so there was a gross free fluid in abdomen and pelvic region with heterogeneous predominantly hyperechoic collection measuring 4.3 into 3.7 centimeter in pouch of Douglas, which is suggestive of ruptured ectopic pregnancy. So, on these investigations, exploratory laparotomy was planned, adequate blood products were reserved and high-risk informed consent were taken, and patient was proceeded to exploratory laparotomy under general anesthesia. When we opened the abdomen in layers, blood clots of around 12 into 12 centimeter were present and left-sided interstitial pregnancy was noted. So, it was ruptured ectopic pregnancy of left interstitium. So, uterus was normal sized with normal remaining tubes and bilateral ovaries were normal. 2 packed cell volumes and 1 FFP transfusion intraoperatively was done after clamp was put at the level of cornua. Clamp was placed and sutured with Vicryl 10. This was the site where the ectopic pregnancy was present, and in this manner, the left salpingectomy was done and the suture with Vicryl 10. Hemostasis was achieved, saline wash was given and sutured with Vicryl 10. Procedure was uneventful and patient was shifted to trauma ICU for better monitoring and post-op care. Then in TICU, 1 PCV, 1 FFP transfusion done post-operatively, managed with injectable antibiotics for 2 days and shifted to oral antibiotics on 3rd day. So, I will have a discussion on very short discussion on ruptured interstitial pregnancy in next few minutes. So, as we all know, the ectopic pregnancy is one in which the fertilized ovum is implanted and developed outside the normal endometrial cavity. So, let's discuss some point about cornual or interstitial ectopic. It is very rare kind of ectopic pregnancy. It is just incidence is just 2 to 3%, where cornual pregnancy or interstitial pregnancy on TVS, we can see the empty uterine cavity, G-sac seen more than 1 centimeter from the most lateral edge of uterine cavity and thin myometrial layer surrounding the G-sac. In this TVS scan, we can see the thin myometrial layer, endomyometrial mantle of just 3 millimeters seen, and the pregnant G-sac is seen in the adnexa. On that, we can diagnose it as a interstitial pregnancy. So, why there are incidence increased in the ectopic pregnancy? So, there is increased prevalence of chronic PID, tubal plastic operations are done very much frequently in these days, assisted reproductive technologies like ovulation induction, intrauterine devices, endometriosis, uterine leiomyoma, and also increased detection rate also increase the incidence of ectopic pregnancies nowadays. Ruptured ectopic pregnancy is a very medical emergency requiring urgent attention to prevent life-threatening complications. So, ruptured ectopic pregnancy is to control the bleeding, remove ectopic pregnancy and safeguard the patient's well-being. So, surgical intervention is typically necessary to address the condition effectively, and specific procedures chosen depend upon the severity of rupture and patient's overall health. So, about rupture of ectopic pregnancy, the classical triad of symptoms we can see that abdominal pain, amenorrhea and vaginal bleeding, along with that vomiting and fainting attacks, weakness and severe degree giddiness we can see. On diagnosis, by keeping in the mind sexually active patient in reproductive age, having amenorrhea and vaginal bleeding, without wasting our time, we can just do the hemoglobin estimation, blood grouping and take the patient for exploratory laparotomy. Examination under anesthesia is not done nowadays and TVS can be done. Laparoscopy is also diagnostic as well as therapeutically can be done. So, my differential diagnosis about ruptured ectopic pregnancies are acute appendicitis, ruptured corpus luteum, twisted ovarian tumor, ruptured chocolate cyst, perforated peptic ulcer. So, management of ruptured ectopic pregnancy is about resuscitation and simultaneous laparotomy. Anti-shock treatment can be given with ringer lactate, blood transfusion, volume replacement therapy with colloids and salpingectomy. So, this is the diagram where we can have an idea about salpingectomy can be done. And so, salpingectomy or tubal resection has been considered the gold standard treatment for ruptured ectopic pregnancy. Thank you.
Sometimes ectopic ruptures even there is no amenorrhea, or sometimes 6 weeks, or like interstitial.
Yes, ma'am.
8 weeks.
About depending upon the tubal factor and the anatomy of the tube, the ampulla has a widest part. So that rupture comparatively late at 10 weeks around, and isthmic portion is comparatively narrowest. So that rupture at 6 to 8 weeks. Cornual pregnancy may extend up to 14 to 16 weeks as there is more space to grow for ectopic pregnancy.
Okay. In one of my case, there was a full-blown 16 weeks pregnancy, IUD baby, and a massive hemoperitoneum. Actually, uterus appeared normal, though slightly a bit small insides. So, just because of this hemoperitoneum, I decided to open. It was a ruptured corneal, rudimentary horn rupture, and HB was almost 2 grams. We had to do the resection of that horn. That's all.
Any questions? Thank you, Dr. Samruddhi.
Thank you everyone.
I would like to invite Dr. Ghate madam, Dr. Chaudhary madam to felicitate Dr. Samruddhi. And Dr. Ghate madam to Dr. Chaudhary madam. I invite Dr. Amruta to proceed further.
Now I would like to invite Dr. Raksha Gaikar to present her case on laparoscopically managed ectopic pregnancy. Dr. Raksha is a junior resident 3 at OBGY Department, Ashwini Rural Medical College and Research Center, Kumbhari. She has done her MBBS from Government Medical College, Kolhapur. She has passed her MRCOG Part 1 and she has won first prize in paper presentation at a state level conference. So over to you, Dr. Raksha.
Good evening, respected teachers, senior members of society, and my dear friends. Myself, Dr. Raksha Gaikar, OBGY resident, would like to present a case of ruptured ectopic pregnancy, laparoscopy or laparotomy under the guidance of Dr. Sudeep Sambharam Sir, Assistant Professor, ARMCH Kumbhari. A 35 years old, Gravida 2, Para 1, Living 1, with previous full-term normal delivery, came with chief complaints of amenorrhea since 1.5 months, pain in abdomen since a week, PV spotting since 2 to 3 days. Her menses were regular, and as per Negli's formula, her period of gestation was 7 weeks plus 5 days. Her abdominal tubal ligation was done 16 years back. In past history, there was a history of tubal recanalization 10 years back. On examination, there was significant pallor, pulse was 108 per minute, blood pressure was 100 by 60 millimeters of mercury. On systemic examination, CNS, cardiovascular and respiratory system were within normal limits. On per abdominal examination, tenderness was present in right iliac region. On bimanual examination, uterus was bulky, 8 to 10 week size, cervical motion tenderness was present, right fornicial fullness was present. So my provisional diagnosis is 35 years old, gravida 2, para 1, living 1 with 7 weeks plus 5 days of gestation with ectopic pregnancy. Her hemoglobin was 8.1, coagulation profile was within normal limits. On USG, it revealed a 4.5 into 2.9 centimeter irregular rounded heterogeneous area seen in right adnexa, surrounding which peripheral rim of vascularity was present. There was no obvious gestational sac seen. The pouch of Douglas showed free fluid, so findings were suggestive of ruptured right tubal ectopic. We proceeded with laparoscopic right salpingectomy. The findings were right fallopian tube was ruptured, left fallopian tube showed adhesions to lateral pelvic wall, bilateral ovaries appeared normal, and hemoperitoneum of 300 ml was observed. Her HPR report confirmed that the specimen had features consistent with ruptured tubal ectopic pregnancy. Now let's have a little discussion on ectopic pregnancy. As this has been discussed, proceeding further, the famous triad. Amongst the risk factors, our case was pertaining to fertility restoration procedures. How do they cause ectopic pregnancy? There is ciliary damage which inhibits peristalsis. Blind pockets are formed due to inflammation of tubal mucosa. There is decrease in fallopian tube lumen diameter and peritubal adhesions are formed. This causes trapment and implantation of fertilized ovum. Jumping on to the surgical management, conservative is salpingostomy, radical is salpingectomy. Let's address the elephant in the room, laparoscopy or laparotomy. Laparoscopy is preferred over laparotomy due to shorter operative time, reduced hospital stay, shorter convalescence period, less adhesion formation, lower thromboembolism episodes post-operatively. This study supports the benefits of laparoscopy over laparotomy. The study has shown mean operative time is significantly shorter in laparoscopic group, further supports that laparoscopy offers advantage of shorter duration of surgery, faster post-op recovery, shorter duration of hospital stays, and lesser requirement of post-op analgesia. Another study supporting the same. This is a review article in which 4 to 5 studies were analyzed and parameters considered were blood loss, positive tubal patency, pregnancy, operating time, analgesics, hospital stay, total hospital cost, and return to normal activity. This article concluded that laparoscopy should be considered as the gold standard method in managing ectopic pregnancies. Laparotomy is preferred in hemodynamically unstable cases. Nevertheless, we have this study which substantiates that the volume of hemoperitoneum did not affect the operative method used. Experienced operators had a 100% success rate at operative laparoscopy in hemodynamically unstable women compared with a 72% success rate with confident operators. This study further substantiates that operative laparoscopy is safe and sustainable in most women with hemodynamic instability. Limitations of laparoscopy, experienced laparoscopic surgeon, availability of laparoscopic instruments. Quoting a statement from Williamson Novak, a ruptured ectopic pregnancy does not necessarily require laparotomy. This study further confirms that laparoscopic surgery is superior to laparotomy in the surgical management of women with ruptured ectopic pregnancy, resulting in lower pain scores, fewer blood transfusions, shorter hospital stay, and fewer days needed for convalescence. Reproductive outcome: tubal patency on the ipsilateral side after conservative laparoscopic management is 84%. The overall intrauterine pregnancy after laparoscopic salpingostomy and salpingectomy are not significantly different. Intrauterine pregnancy rates and recurrent ectopic pregnancy rates are similar in both modalities, laparoscopy and laparotomy. This is a study of European Society of Ectopic Pregnancy. It interprets that in women with tubal pregnancy and a healthy contralateral tube, salpingotomy does not significantly improve fertility prospects compared with salpingectomy. This is a review article which concludes that no significant difference in intrauterine pregnancy rates or repeat ectopic pregnancy rates were found after radical or conservative surgical management for tubal pregnancy. This is a randomized trial substantiating the same. So I conclude by saying that laparoscopy should be the preferred modality in ectopic pregnancy, irrespective of hemodynamic status. Intrauterine pregnancy rates and recurrent ectopic pregnancy rates are similar in laparoscopy as well as laparotomy. The intrauterine pregnancy rates after laparoscopic, conservative and radical surgical treatment are not significantly different. These are my references. Thank you all for patient listening.
I beg to differ from different studies which you have quoted, that hemodynamically unstable patient, should we really go ahead with laparoscopic approach or laparotomy? When we are, both the surgeries need to be done under general anesthesia undoubtedly, because patient is hemodynamically unstable, and what saves the patient is how rapidly you achieve hemostasis. Okay. In open surgery, you can get the uterus out and apply the clamps and stop the bleeding in no time. In laparoscopy, you have to clear the hemoperitoneum first, which is full of clots, may be difficult for one. Okay. So howsoever expert the laparoscopic surgeon is, he may take a little more time in reaching the target and achieving hemostasis. That's what I would like to say. Anybody? Sudeep, do you want to say?
Objective of immediately after putting the trocar will be first to hold the bleeding point, irrespective of how much the hemoperitoneum is, and also if only the difficulty will be there only when we are not able to find the tube where the bleeding point is. We can assist that, make it easier by anteverting the uterus vaginally, so that it appears up during that process. Head low, yeah. Let the intrauterine blood can go descend down when we go do the head low, and you can antevert the uterus simultaneously so that we can come to the point of bleeding immediately. Depends upon, that is a limitation, that limitation of laparoscopy, we have mentioned that also, that it depends upon the experience of the surgeon and and the equipment.
One thing with the laparoscopy is that there is a bleeding and the red color more absorbs the light. So vision is definitely poor on the laparoscopy on the first time, but if we take a suctions and go ahead with that, then they need to become more.
So you would advise everybody to go ahead with castors. Okay. Another thing, just to continue the discussion, conservative surgeries on fallopian tubes, whether you are doing milking or you are doing salpingostomy, once a damaged tube is always a damaged tube. Okay. So I would not that because we are practicing in IVF, I would not conserve any damaged fallopian tube. Yeah, Methotrexate, not doing any surgical intervention, I accept. Okay, and wait for the resolution of that ectopic. But doing a conservative surgery on the fallopian tube, my personal opinion, I mean, I would not be very much for that.
Actually, I wanted to ask one question to my seniors and colleagues. One patient had underwent tuboplasty 1 month back, and she immediately conceived in the next month. And one day she came with very severe pain, and on sonography it turned out to be ruptured ectopic on the same site where the tuboplasty was done. And she was very reluctant for immediate surgery for that. And hemodynamically she was so stable, just she was having dyspareunia and pain at the time, severe pain in the abdomen at that time only. Then I had nothing in my hand to rather than convincing her. She said, I will come tomorrow. And she came day after tomorrow. Then I thought, let us do beta ICG again. I have done beta ICG, and the beta ICG was decreasing. So then I thought, let us give a chance. She doesn't want the surgery and patient is totally stable and beta ICG is decreasing. So again I called her after 3 days and did the beta ICG levels, and gradually in the due course of time beta ICG totally came to 2 level, 2 mil international units level, and it was managed, and the POD was totally cleared off after 1 month, and there was no evidence of any ectopic on sonography then. So I wanted to ask whether should I have interfered at that time, or nature has taken care of this thing?
You were not present for the first case. Conservative management of an ectopic.
You are not present for the first case. First case was that only. That expectant management. Not to do anything. Dr. Vijay Pawar is here. So, and one thing is you come in time to from first case. So there will not be any discussion again and again. That is the thing. So I mean, it is the first case that we discussed, and we started 20 minutes. We waited for 20 minutes.
Now I would like to invite Dr. Sudeep Sambaram sir and Dr. Ghate madam to felicitate Dr. Raksha. Now I would like to invite Dr. Sneha Devkar to present a case on ovarian ectopic pregnancy.
Good evening everyone, here presenting case of ovarian ectopic pregnancy under guidance of Dr. Ajit Gandhi sir. The patient was 28 years old, gravida 3, para 1, live 1, abortion 1, and she was presented with complaint of amenorrhea of 1.5 months and also complaining of abdominal pain. Her menstrual history, she had regular cycles of 28 to 30 days with average flow. Obstetric history, she had 1 live birth of 7 years old female done by cesarean section, and 1 abortion, 6 weeks induced abortion in view of failure of contraception. She was stable. On examination she was stable. On per abdomen examination there was tenderness present, and on per vaginal examination there was cervical motion tenderness and right fornical tenderness present. Her UPT was positive and beta HCG was 6000 international unit. Hemoglobin was normal. On USG transvaginal sonography, right ovary was enlarged, shows evidence of a complex echo, highly vascular lesion. Probe tenderness is noted on this lesion. Ovary could not be identified separately from this lesion, and there is evidence of minimal free fluid is noted in the peritoneal cavity. This is highly suggestive of right ovarian ectopic. This was the transvaginal findings. Then the patient was planned for the laparoscopic surgery as well as exploratory laparotomy. The procedure was done under general anesthesia Laparoscopic surgery with resection of right ovary done, and the tissue was sent for HPR. Post-operative care, she was shifted to ward, antibiotic coverage was started. Patient was monitored routinely for pulse blood pressure and she was discharged on post-op day 3. As patient was in reproductive age and willing for further conception, fertility has been preserved. Today her gestational age is 9 weeks 4 days. Yes, sir. She is conceived. One. So it was managed laparoscopically. There is the criteria, Spiegelberg criteria for the diagnosis. It includes ipsilateral tube is intact and distinct from the ovary. The ectopic pregnancy occupies the ovary. The third one is the ectopic pregnancy is connected by the utero-ovarian ligament to the uterus, and ovarian tissue can be demonstrated histologically. Then the management modalities. Classically, management for ovarian pregnancies has been surgical. Small lesions can be managed by ovarian wedge resection, and larger lesion requires oophorectomy. Thank you. Yes.
Any questions for Dr. Sneha?
Ultrasound etc. was not there. Today I think it will hardly, because one is that it should be surrounded by ovarian tissue. We are not going to remove the ovarian tissue at all.
Thank you, Dr. Sneha. Now I would like to invite Dr. Sushmita to present a case on silent ectopic pregnancy. Dr. Sushmita is a second-year OBGY resident in Markandeya Rugnalaya, Solapur. She has done her MBBS from Nandyal Medical College, Andhra Pradesh.
Good evening, respected teachers and my dear friends. I thank OBG Society for giving this opportunity. I would like to present silent ectopic pregnancy under the guidance of Dr. Neeta Ghate ma'am. Here is my case. 27-year-old female with Gravida 2 Para 1 Live 1 came to OPD on 8th February 2024 with UPT positive, which was done 2 days back. She came with presenting complaints PV bleeding since 1 day, lower abdomen pain since 1 day. Patient was apparently normal 1 day back, then she had mild PV bleeding, followed by lower abdomen pain which was sudden in onset, acute in nature. No history of shoulder pain, no history of generalized weakness and fatigue. Obstetric history, her marital life was 3 years, continuous marriage. First LSS was done, 1.5 year male child. LSS was done for CPD. Her baby birth weight was 2.8 kg. Baby cried immediately after birth. Child is immunized till date. Puerperial period was uneventful. Second gravida was present pregnancy. Spontaneous conception which was detected 2 days back by UPT. No history of contraceptive usage. Menstrual history, she attained menarche at the age of 14 years. Her cycles were regular, 3 to 4 days with normal flow, 28-day cycle. No history of pain during menstruation, no history of passes of cloths. Her LMP was 4 January 2024. Not known case of diabetic mellitus, hypertension, TB, thyroid disorder. No past surgical history except previous LSEs. No history of similar complaints in the past. Family history was not significant. Personal history, she takes mixed diet, good appetite, normal bowel and bladder habits. Normal sleep pattern, no history of substance abuse, no history of allergy to drugs. General examination, patient was conscious, alert, oriented to time, place, person, moderately built and nourished, no pallor, no icterus, cyanosis, clubbing, lymphadenopathy or edema. On examination, BP was 120/80, pulse rate 80 per minute, saturation 99%. Systemic examination was all normal. Per abdomen, on inspection, no distension over abdomen. Previous LSS scar noted, which was healthy. Palpation, mild tenderness over right side of abdomen, no guarding and rigidity, no palpable organomegaly. Auscultation, bowel sounds were heard. Per speculum was done, slight bleeding through os present. PV bleeding, uterine size was not elicited. Immediately we advised USG and report suggestive of uterine cavity is empty on collar Doppler. Cervical cavity is empty. Lot of fluid collection noted surrounding uterus in pouch of Douglas. Right fallopian tube is enlarged, edematous, suggestive of subacute, already ruptured right tubal pregnancy. No active bleeding at present. No gestational sac noted. Only enlarged right tube detected. They advised lab test to correlate with beta HCG or recent UPT test. Immediately investigations were sent and patient was posted for laparoscopic exploration. Here are the USG images. We can note in right adnexa a lot of fluid collection were present and uterine cavity is empty and gestational sac was not there. Immediately investigations were traced. Blood group was B positive and strength for cross matching. HB 12 gram per DL. WBC 11,700, platelets 2,77,000, serology was negative for HIV, HPSAG and urine routine was normal. Patient was presented with acute presentation, henceforth posted surgery immediately. Meanwhile, patient was hemodynamically stable. Patient was given general anesthesia and placed in supine position. Lower abdomen and vagina were thoroughly disinfected and draped. Foley's catheter was used to empty the bladder. Small horizontal incision taken at infraumbilical region using 10 mm trocar for carbon dioxide insufflation and pneumoperitoneum created, followed by right and left 2.5 cm anterior superior iliac spine, small incision taken and trocar inserted. Here are the laparoscopic findings. Right-sided tubal abortion was found already and hemoperitoneum seen. Clots were removed followed by products in the right-sided tube were removed and minimal blood loss was present, which was secured by Codget. And hemostasis was achieved. Bilateral ovaries were healthy. Peritonization was done. Skin was closed with ethylone. Procedure, remaining products were sent for HPR. This is an image which we can see right fallopian tube was enlarged and edematous and minimal blood loss was seen. This during operation minimal blood loss was there and we have secured with catgut. One more is done. And this is an in which we are removing products in right side of the fallopian tube. Already abortion was done, tubal abortion had happened and we are removing products. Later, HPR reports confirms that on gross examination, multiple grayish brown tissue measures 5 into 4 into 1 centimeter. A few gray white bits measured 1 centimeter. It was stained by hematoxylin and eosin. On microscopic examination, right fallopian tubal tissue shows mostly blood clots and few fragments of fibrovascular tissue. Sparse leukocytes are seen. No villi or tubal viable tissues are seen. Endometrium is composed of tortuous glands lined by low columnar epithelium. They are arranged back to back. Many glands show secretory activity. Stroma is moderately loose and edematous with prominent pre-residual changes suggestive of secretory hypertrophy. On post-op period, it was uneventful. Prophylactically, it was managed with injection methotrexate on first day and third day with alternative leucovorin on second day and fourth post-op day. Beta HCG was not done as patient was not affordable. Post-op day 1, we have repeated CBC, HB and WBC platelets were all in within normal limits. Patient was hemodynamically stable throughout post-op period. She was discharged on post-op day 6th. Thank you.
Any questions for Dr. Sushmita?
Symptom, she had good symptoms. Why you said silent ectopic?
She had written symptoms, but patient is staff nurse in our OT and she is totally asymptomatic. She is not having acute pain. And on PV also she is not having pain. And as she is working in our hospital, treatment is free in our hospital. So she don't go for beta HCG. And
So it is not silent.
No, patient is not having acute pain.
Acute नहीं है, पण pain होतो ना.
No, she don't allow me to do the PV exam.
But patient, the most important is pain. But patient, she said she had pain. So once pain comes, means it's not silent. I will say.
Okay. Tubal abortion, we removed the products, but we are not sure the tube is edematous. And I think that I did DNC also, because there might be the heterotropic pregnancy, because one of my patient had that. That's why. And methotrexate is given because in tubal abortion we are not done anything to the tube. We only removed the products which have aborted from the tube. Which we have not done milking. Only thing is there is one bleeder is there. That's why we put the stitch there. We have not done anything for the tube and prophylactically we have given methotrexate.
No. Where you have put that stitch, we could not recognize that place.
It is below the femoral end. There was a bleeder. Below the femoral end, there was a bleeder, and we take stitch over there, and the rest of the tube is normal. Only edema of the tube is there. There is no like gestational sac or inflammation of the tube or bulging of the tube is not there. That's why. We are not sure now whether we removed the sac or not. We are not sure now.
No,
If remaining chorionic tissue remain there, then
scientific discussion, don't take it personally, but how far it is justified to give the methotrexate without doing the beta HCG level?
we are doing with monitoring. Not willing. Okay, next time we'll do.
Your ultrasound findings, you have mentioned that ultrasound showed no evidence of fresh bleeding.
No, ultrasound is having hemoperitoneum signs.
What did she mention on the ultrasound findings? Can you repeat that? Yeah. No, the discussion, whatever the written material is there. And
UAG findings.
next slide. Next slide. No, previous slide. Yeah, no active bleeding at present. Last but third line.
No
I am curious, Dr. Gandhi, that can ultrasound give such a finding that there is no active.
The sonologist had written that.
Because Dr. Gandhi is there, I wanted to ask the question. And looking at that loop which you passed, we thought that you are ligating the whole tube.
No, below tube it is.
It is at the femoral end.
Huh.
Okay. So, was bipolar not working, or you are more familiar with the stitches?
No, I have not done. I done along with surgeon, and he said that I'll pass loop and that bleeding will be stopped. I have not used any cautery for that.
Okay.
Thank you, Dr. Sushmita. I would like to invite Dr. Ghate Madam to felicitate Dr. Sushmita. Also, I would like to invite Dr. Sardesai Madam to felicitate Ghate Madam. Now, I would like to hand over the mic to Dr. Chandrakant for further proceeding.
I think 3 cases are remaining. With this much cases, we are all convinced that the incidence of ectopic pregnancy is increasing despite of all antibiotics. I would like to invite Dr. Sukanya for present a next case. She is junior resident from Dr. VM Medical College. Over to you, Dr. Sukanya.
Myself, Dr. Sukanya Hulgunde. I am junior resident at VMGMC Solapur. I am here to present a rare case of cervical ectopic pregnancy guided by Dr. Vidya Tirankar ma'am, head of the department at VMGMC Solapur of OBGY department. A 30-year-old patient, Mrs. XYZ, hailing from Solapur, Hindu housewife belonging to the lower socio-economic class. She is gravida 4 para 2 living to abortion 1 with 6 weeks of amenorrhea, presented with complaints of moderate PB bleeding since 7 days and mild pain in abdomen. No history of fever, no history of urinary tract infection, no history of assisted reproductive techniques, no history of contraceptive use. Obstetric history, she is married since 11 years, non-consanguineous marriage. She is having 2 female childs of 10 years and 6 years, delivered by full-term cesarean section.
In Gravida 3, she is spontaneously incomplete abortion of 6 weeks duration. 3 years back check curettage done for the same. Gravida 4, she is a present pregnancy. Menstrual history, patient is having regular menstrual flow of 28 days cycle lasting for 3 to 4 days. Her LMP is 1 April 2024. By date, period of gestation is 6 weeks. On examination, patient is, general condition of the patient is fair, conscious, oriented to time, place and person, afebrile, height is 155 cm, weight is 65 kg, pulse is 98 per minute, BP is 120 by 80 mmHg, respiratory rate is 18 per minute, saturation is 98%, pallor present, no icterus, no edema. On systemic examination, CVS, RS within normal limit. On per abdomen examination, soft, non-tender, previous cesarean scar was present, which is healthy. On per speculum examination, cervix appears bulky, os closed, violet in color and bleeding present. So based on the history and examination, my provisional diagnosis is Gravida 4 para 2 leading to abortion 1 with 6 weeks of cervical ectopic pregnancy. Investigations done, HB 11.6 gram%, platelet 3,30,000, WBC count 6,000, hematocrit 38.6. Her liver function test and kidney function tests were within normal limit. Urine routine microscopy were normal. INR 0.9. The serostatus of the patient is non-reactive. Her UPT is done to confirm the pregnancy. The UPT came out to be positive. So on USG, irregular gestational sac with poor decidual reaction noted in cervical region. Fetal pole shows absent cardiac activity with 7 by 6 by 4 mm subchorionic hematoma, CRL of 8.5 mm, and we advise patient for a to do beta SCG, which is 6,500 milli-international units per ml. So I would like to show a video of the same patient which is recorded in our institute of the cervical pregnancy. This shows the cervical ectopic pregnancy in the endocervical canal. Internal os is closed, so we exclude the incomplete abortion. So based on the diagnosis and investigations, patient explained about a treatment plan and started on medical management. Injection methotrexate single dose regimen given, dose calculated as 1 mg per kg, total dose of 65 mg of injection methotrexate given by intramuscular route. Patient monitor for the following things: abdominal pain, vaginal bleeding, fall in hemoglobin levels and effectiveness of the therapy. On day 2, patient gave a history of passage of mass with blood clots. As patient was not affordable, serial beta HCG level monitoring could not be done. Hence, we did serial UPT test. By day 4, it came weakly positive, and by day 7, it came negative. So on day 8, USG done, which shows no evidence of written products of conception. Hospital stay went uneventful and patient discharged home safely. So we have a little bit of discussion on cervical ectopic pregnancy. Cervical ectopic pregnancy is a rare condition with an incidence of less than 1% of all ectopic pregnancies. It is associated with high morbidity and mortality potential. Timely intervention is required to preserve the fertility and avoid need for hysterectomy. In the past, cervical pregnancy was associated with significant hemorrhage and was treated presumptively with hysterectomy. Improved ultrasound resolution and earlier detection of these pregnancies has led to the development of more conservative treatments that attempt to limit the morbidity and preserve fertility. This rare form of cervical pregnancy is one in which the ovum becomes implanted in the cervical canal and distance it as it grows. The condition can be mistaken for the incomplete abortion of a normally sited pregnancy. Clinically, both are differentiated by a sliding sign. Sliding sign is seen when an expelling gestational sac slides against the endocervical canal with gentle pressure on the cervix with a vaginal probe, which is not occur with the implanted cervical pregnancy. So diagnosis of the cervical ectopic pregnancy is by two criteria. One is Rubin's and one is Palman's criteria. So the Rubin's criteria is cervix becomes soft and enlarged than uterus, placental tissue attachment in endocervical region below the internal os or below the entrance of the uterine vessels or below the peritoneal reflection. No fetal part in the corpus of the uterus. Ultrasound criteria for the cervical pregnancy, which is also known as the Palman's criteria. Empty uterine cavity or the presence of a false gestational sac only. decidual transformation of the endometrium, diffuse uterine wall structure, hourglass uterine shape, balloon cervical canal, gestational sac in the endocervix, placental tissue is the cervical canal, closed internal os. Various treatment modalities for the cervical pregnancies are reduction of the blood supply by doing the embolization or the ligations of the uterine artery or the cervical artery, surgical excision of the trophoblast, then intraamniotic feticide, systemic chemotherapy we can also use. So overall conclusion of the discussion is, if patient presented in the first trimester with cervical pregnancy, if she is hemodynamically stable without severe bleeding, then we can go for a medical management by methotrexate. IM or locally, we can give a single dose regimen or a multiple dose regimen. Failure of medical treatment happens if beta HCG levels are more than 10,000 or if CRL more than 10 mm or if there is a cardiac activity present. For this, we can add on intraamniotic methotrexate or KCl for a feticide. If medical management fails or contraindicated, then we can go for a fertility sparing surgical methods like excision of the trophoblast via curettage or aspiration. Thank you so much. Ma'am, it takes 7 days to came UPT negative. Ma'am, on day 2, she passes the blood clots with mass.
Immediately she aborted.
Yes, ma'am.
You all were lucky because these cervical pregnancies
It's
bleed
very rare.
profusely when they are.
The scar pregnancy is above the internal os and the cervical ectopic pregnancy is below the internal os. And also the placental tissue in the endocervical canal. And there is a no fetal part shows in the corpus of the uterus. In scar pregnancy, it shows in the corpus of the uterus below the internal os, above the internal os.
Cervical is below.
Yes. I am very thankful to SOGS for giving me this opportunity.
There is no need of curettage after the abortion. When you come, there is a pass of clot. You see this.
If there is a written products of conception, we can go for the surgical excision. But in my case, there is no written products of conception.
No,
so
after passage of clot, there is no trophoblast tissue. There is no need of curettage.
Yes, ma'am, no need. Profuse bleeding, yes. Thank you so much.
Thank you, Dr. Sukanya. I would like to invite Dr. Dabde sir to felicitate Dr. Sukanya. Like to invite Dr. Ghate madam. Next speaker is Dr. Ajit Gandhi sir. He has need no introduction. He is graduate from the VM Medical College and excellent academic achievements, and he is special interest in fetal medicine, and the special mention is he has done more than 200 intrauterine blood transfusions. Over to you, sir.
Good evening, everybody. We had almost all locations in the pelvis, and I'm going to have the rarest of the things which we see in the practice about experience of 2 heterotopic pregnancies. The first heterotopic pregnancy, if you remember, I had presented during our one of the meetings during COVID times. Unfortunately, I don't have the material of that pregnancy right now, but then I'll present that history first, that it was a case of primary infertility who conceived with IUI. And then she had a heterotopic pregnancy. One was live in the intrauterine cavity and the second was in the cervical canal. The beta HCG was pretty high. It was more than 20,000. Obviously, 2 sacs growing a live pregnancy, you expect that kind of beta HCG. So in this case, what we did is we injected 5 milligram of methotrexate intrasac ultrasound guided into the cervical pregnancy. It did its job, but then also we lost the intrauterine pregnancy. both the embryos died. Beta HCG fell. When the beta HCG came below 500, then we did a gentle curettage and removed both the pregnancies. Learning a lesson from this case, when I had a similar second pregnancy a year and a half back, what we did, it was a IVF conception, similar case. One was a live intrauterine pregnancy and one was a live cervical pregnancy. And then this time I had decided that I would not damage to the intrauterine pregnancy, and then I adopted a totally different technique. These are the images of this second pregnancy. You can see here, this is a cervical pregnancy. You can see down over here. This is an intrauterine sac. This is a cervical sac. And you can see the cardiac activity into the cervical sac. What I did in this case, we injected little vasopressin into the cervix. We did the whole bipolar resection of the cervical pregnancy, and then we put a tight circular stitch around the cervix, and it worked. There was no bleeding, there was no intrauterine collection of blood. The intrauterine pregnancy continued to grow. The patient went to 31-32 weeks. This patient was from interior of Karnataka, quite an interior place, where probably she went into preterm labor there, and in a government hospital she underwent C-section. Unfortunately, that baby died because of the prematurity. But then this pregnancy we could intrauterine pregnancy, I could salvage by this technique. The cervical cerclage and excision is a procedure which has been described in the literature. When I went through the literature, there are about 4 or 5 case reports of this kind of technique which has been used to treat heterotopic pregnancy with a combination of intrauterine and cervical pregnancy. Thank you. KCL, yes, you could have, but then even if we inject the KCL, the trophoblast would not die immediately. It's cervical canal trophoblast. So what you would do for that? If it starts bleeding, then how you will manage? We used a bipolar current, the forceps, and resected the whole thing and put a tight circlage, and it did work. But then it would have harmed the intrauterine pregnancy also.
No, in the cervix I am saying. If you put a Foley's catheter, cut away the tip, and we put in and inflate the bulb, that also will act as a tamponade. And cervical dilatation. Okay.
It would induce the cervical dilatation, risk of infection.
It might.
And maybe that if it slips out, she might start bleeding also. Black silk. Routinely आपण जे tightening ला वापरतो.
Cerclage means you have descending cervicals, you have obliterated in short.
No, the routine McDonald cerclage.
By doing this, you have obliterated.
Obliterated the cavity. The compression stitch, like it worked like a compression stitch.
Okay.
The anticipated worry was whether this cervical pregnancy bleeds inside the uterine cavity, but then it did not. The pregnancy remained intact. I had placed the stitch little higher, and it did work.
Thank you, sir. I would like to invite Dr. Dabde sir to felicitate Dr. Ajit Gandhi sir. For enlightening us with such a rare case. I would like to invite all to have a Puran Poli in Pangat fashion. Okay, after this last case. No, I'm announcing that everyone should be present for that. I would like to invite Dr. Avantika Thomre. She is junior resident from OBGY department, Ashwini Rural Medical College. She has taken a gold medal in the obstetric and gynecology, and she has presented a paper and posters in various conferences. She is presenting on corpus luteal hemoperitoneum. That was discussed with the first case.
Yes, sir.
Okay, thank you. Over to you, Dr. Avantika.
Good evening, respected teachers, senior members of the society, and my dear friends. Myself, Dr. Avantika Thomre, junior resident. I am presenting this case under the guidance of Dr. Vrunda Chaudhary Madam, Professor and Head, Dr. Shraddha Tharkar Madam, senior resident, Department of OBGY, ARMCH Kumbhari. My topic is massive hemoperitoneum from ruptured corpus luteal cyst in a patient on anticoagulation therapy. Our patient, 34 years old, para 3 living to D1, she presented to the casualty with 2 months of amenorrhea, generalized pain in abdomen, nausea, 3 episodes of vomiting, chest pain and difficulty in breathing since 7 to 8 hours. She had irregular menstrual cycles since 1 year, where she bled for 3 to 4 days at an interval of every 1.5 to 2 months. It was not associated with any passage of clots. The patient was a known case of hypothyroidism and was diagnosed with rheumatic heart disease with severe mitral stenosis, pulmonary hypertension and atrial fibrillation, for which she underwent metallic mitral valve replacement therapy 2 years back. Following which, the patient was started on tablet warfarin, tablet ecosprin, tablet amiodarone and tablet thyroxine. But the patient was not compliant with anticoagulation therapy or the monitoring, and her last reports were 6 months back and they were within normal limit. On examination, she was conscious and cooperative. Significant pallor was present. Her pulse was 120 beats per minute and her BP was 90 by 60 millimeters of mercury. Her cardiovascular and respiratory system examination were within normal parameters. On per abdomen examination, there was distinct distension with marked tenderness in the iliac fossa and hypogastrium with rebound tenderness. On per vaginal examination, cervical motion tenderness was present and left forniacial tenderness was also present. We considered the following differentials of ruptured ectopic pregnancy, ruptured adnexal mass, acute exacerbation of PID and torsion of the adnexal mass. But to our surprise, the urine pregnancy test came out to be negative. Her blood profile revealed severe anemia with normochromic normocytic features on the peripheral smear. Her coagulation profile was grossly deranged with an INR of 4.24. The ultrasonography revealed a heterogeneous vascular correction of 11 by 6 centimeter in the left adnexa. The ovary was not seen separately. Massive free fluid was present in the pouch of Douglas, and it was suggestive of ruptured ovarian cyst or ruptured ectopic pregnancy. Because the patient was an operated case of MVR, 2D echo was done and the metallic valve was in situ with an ejection fraction of 40%. With consultation with the cardiovascular thoracic team, her anticoagulants ecosprin and warfarin were put on hold, and in view of the deteriorating condition and evidence of hemorrhage with blood and blood products in hand, patient was posted for laparotomy. Under general anesthesia, the abdomen was opened, clots were present in the pouch of Douglas and hemoperitoneum of 1 liter was drained out. Active bleeding from the cyst wall was noted, cystectomy done. The bleeding site was sutured with an absorbable suture. Incised tissue was sent for HPR. All other visceral organs were inspected and found to be normal. There were no signs of hemorrhage, endometriosis or adhesion present. The histopathology report was traced and it came out to be a hemorrhagic corpus luteum. The patient was shifted to CVTS ICU, antibiotic coverage was started. With again the consultation of CVTS, the doses of anticoagulants were adjusted. Patient was monitored serially for improvement in CBC and coagulation profile. She was discharged on tablet warfarin 3 mg and the contraception counseling was done for the patient. India has known for a high prevalence of rheumatic heart disease, and with increasing number of patients undergoing mitral valve replacement and mandatory use of anticoagulants post MVR, the patients presenting with drug-induced coagulopathy have increased. More and more recent case reports of massive hemoperitoneum from ruptured corpus luteum cyst associated with such conditions have been seen. Corpus luteum is a functional cyst in the luteal phase which regresses spontaneously into corpus albicans. It is a thin-walled vascular structure. The rate of bloodstream to the corpus luteum surpasses any adult organ. Rapid growth and high vascularity of the corpus luteum in the intraluteal hemorrhage and leads to intraluteal hemorrhage and formation of a hemorrhagic cyst. Ongoing bleeding into the cyst can result in rapid enlargement, spontaneous rupture and leakage of blood into the peritoneal cavity. Most follicular cysts will spontaneously regress and medical intervention is usually limited to symptomatic control. According to literature, when the INR is between 3 to 4.4, there is the highest risk of bleeding in such conditions. Following are some case reports substantiating the diagnosis of massive hemoperitoneum in such patients. The radiographic features are typically identical to a ruptured ectopic pregnancy, and as in our case, a UPT might help in differentiating the both. The features are of complex cyst, rim of increased echogenicity and peripheral vascularity as is seen in ectopic pregnancy also. Here we can see a collapsed cyst with a hyperechogenic rim and on Doppler a peripheral vascularity ring, that is a ring of fire sign is seen. Again here in the first image we can see the crenulated borders and in the second image an empty uterine cavity. Management in an unstable patient, surgical management is taken into consideration, and if the patient is hemodynamically stable, conservative approach can be used. Corpus luteal cyst rupture is fatal in cases of unmonitored coagulation. It needs strict and vigilant monitoring of the coagulation profile. The mode of management depends upon the amount of hemorrhage and the hemodynamic status of the patient. In stable cases, conservative management should be the first mode, while in unstable cases, after correcting the coagulation profile, surgical exploration is necessary. These are my references. Thank you.
Any questions from audience? I would like to invite Dr. Chaudhary Madam to felicitate Dr. Avantika. Thank you, Dr. Avantika.
Here is one announcement. Tomorrow there is a yoga day. So we have to come at 7 to 8 a.m. Dr. Ashok Vinsurkar sir is a yoga teacher. He is a very good teacher. Please join tomorrow. Without forget. Sir, votes of thanks.
There is one more announcement. On 6th of July, there is a CME at Sarovar from SOGS. The CME is on AUB, abnormal uterine bleeding, and sponsored by Myrina. And 2 speakers are coming there from SOGS. It is evening CME, only 1 or 2 hour CME followed by delicious dinner. So please come.
I would like to thank all the residents, Dr. Arun Guge, Dr. Sneha, Dr. Samruddhi, Dr. Raksha, Dr. Sushmita, Dr. Sukanya, and Dr. Avantika. Special thanks to Dr. Ajit Gandhi sir for 3 cases ectopic, and thank you to all seniors for their valuable inputs. I would like to invite all you to have take the delicious puranpoli.
सगळेजण पंक्तीला या. पंगत 30 जणांची आहे. तर प्लीज कम.
Academic partner Sun Pharma.